Hello, guys. Welcome to the Couple Nurses podcast with your hosts, Matt Solarchik and Peter Findera. How you doing today, Petey?
I'm doing good, man. The weather's nice over here. It's in the 30s. I woke up, and when I woke up, it was pretty cold, but it warmed up here in Chicago. So hopefully, you get a nice March.
Nice, beautiful review of the weather from PD again. So, this is the Couple Nurses podcast where we tackle current health news and hot nursing topics, one conversation at a time. Those that are returning, thank you guys for chilling with us and hanging out with us. We're going to keep delivering this awesome content. We're going to keep being funnier because PD's just, giving the laughies all the
I'm
time.
actually, I'm actually drinking milk right now, leftover milk. So it should be interesting here.
Leftover milk from last night.
No, from what I ate today before for a cinnamon roll. I had a cinnamon roll before we started podcasting. Leftover milk. I'm not gonna throw it out. I don't want to go to waste.
Okay. Well, you tell your viewers not to eat sugar, but here you're eating a cinnamon roll, and that's totally okay. I understand, Peter. You're a human being just like everybody else that listens.
It was a half of a cinnamon roll, and it's gonna expire tomorrow. So, like I said, I'm not a very wasteful individual, and you just gotta eat it with a glass of milk, straight from the
Exactly.
cow, straight from the teat.
So those that are new, welcome. Please, guys, if you guys like the podcast, give us 5 stars and rank us. It helps the search engine. It helps us being more exposed, and we're seeing a difference in that. So let's continue doing that. So what are we talking about today, PD?
Well, today, guys, we're going to talk about something called nano transfection technology. It's a new technology being developed, and it helps your skin and your cells regrow, and also has the potential to change the cell structure and actually change the cell function. So we're talking a little bit about that, how it's going to progress in the future, and what we could expect from it. We're also going to talk about SIADH and diabetes insipidus. Diabetes insipidus, people think diabetes, blood sugar. This is more about water, and I'm sure you nursing people out there are gonna like this one.
Yeah, it's more neuro based, which is not our cup of tea, but it is what it is. I like talking about neuro once in a while,
Or a cup
but
of
have
milk.
or over a cup of milk. But having those patients aren't. I don't know, man. Having neuro patients sometimes is not annoying, but it's a whole different ballpark, man. It's like learning a whole new system compared to like cardiac.
Yeah, I'm not a fan of neuro. That's why I get zero neuro patients.
Oh yeah,
No complaints.
you're full cardiac. So this technology stands for TNT. So are we blowing up something on the patient's body?
TNT, it's dynamite. That song you play in the background here. No, so this is actually kind of looks like a little chip that they put on your skin, and this actually like zaps your cells and changes their function, and it also like per not prevents but also starts to help the cells like divide. It helps regrow cells. I know majority of research that they're doing right now, it's on skin, like with burns, with like trauma, and it kind of shocks the cell and it makes it like proliferate. It makes it grow. It makes it divide. But it's also interesting because this like carrier chip has like different enzymes in it, has different kind of components, which actually help the extracellular matrix uh, it gives those components because the extracellular matrix is a big proponent of like cell division, cell growth. Actually helps our cells function, helps with adhesion and a bunch of other things. So this actually chip not only does it zap, it also carries certain enzymes and certain chemicals and certain not really cells, just like components that actually help your cells develop and kind of change their function. So it's like basically getting like a giant shipment of cargo into the cell, which either can change the cell or can help that cell divide.
And those that don't know, the extracellular matrix is everything around the cells. So you have cells, and in between that, you have this extracellular matrix, which more and more we're starting to realize, just like PD says, it's helping with cell division, cell growth, and to promote healthy growth of cells. And it's interesting how, let's take a step back to like burn patients, right? Like right now, the big thing is stem cell therapy, and we can take stem cells at like a vacuum, suck them out of our body from a different part. And I think what I'm not exactly sure how they do that, but they're able to spray stem cells onto burn victims and help them regrow. But here you're just actually taking the healthy cells and you're zapping them, you're saying, with this chip, and it's able to stimulate them cell growth.
Exactly. Yeah. So you're able to stimulate them, and some of the research is even showing that they're able to actually reprogram the cell to do something different. So you can reprogram like a epithelial cell, like a skin cell, to turn into like the cell that's made up of like blood vessels. Like you could actually transform these cells without actually needing stem cells. Because when we think of like creating new cells, we think of the way that our cells are derived from stem cells, and stem cells are the most basic cell, and all functional cells are derived from that stem cell. What this technology is able to do in a certain aspect is they're able to take regular functioning cells, like you could take like your osteoblast, you could take like your epithelial cells, and you can actually change their function without needing that stem cell, without any kind of conversion to do the stem cell.
And it's saying it's 98% efficient, and it does not hurt. These electrical charges that you're giving the patient aren't even felt. And they did a study on mice. Poor mice, man, they're always getting tested.
That's what you got to.
But
I mean, they breed like crazy. You got to use them. I mean, it does kind of suck. Where like how a few years ago there was like that issue when they taste or not taste, but they test makeup on like animals. Like they would test makeup on like pigs, cows, just to see how the makeup looks and kind of how it reacts to the skin. Well, that's kind of sucks for these mice because they're lab grown mice, and their one purpose in life is to just get tested on. Like they're throwaways.
it does suck. I mean, and look what we've been doing. We're able to genetically modify a rat with or let's call them a mouse. You want to call them a mouse, mice with a freaking ear on their back, or they're glow
Meese.
in the dark. Like they're able to replicate them so much. But after the study, what they did with TNT therapy, they were able to restore blood flow in injured mice and reprogram their skin cells to like revascular. So that'd be pretty cool if we could use this technology in the future to help, for example, stroke induced humans, since they're not mice, and help them restore blood flow, or you're able to restore blood flow in like the legs for patients that have like peripheral vascular disease.
Yeah,
I
just to see what's gonna happen because like you said with like the whole with the like the ischemic stroke, like your brain loses oxygen and like that area gets kind of devascularized or whatever you want to say. Same with like the cardiac issues. Like once you have an MI, like that part of your heart's ischemic. Like your heart muscles, your heart cells do not they don't replicate. So all the cells you have in your heart, that's the cells you're gonna have until you die. So it'd be interesting to see if maybe they could instead of stem cells, maybe they could put this chip in like your heart and you said revascularize. Maybe you could revascularize certain parts of your heart, or even stimulate these cardiac cells to divide. Like imagine if you could figure out a way to have like your heart cells divide. Like that would be like a drastic change in science. And if we could figure out a way to be able to uh, multiply and like breed cardiac cells naturally in our heart, like people are going to be able to live to like over 100 years because how many people die of MI? Cardiovascular disease is one of the number one killers in the United States and in the world. And just imagine if you could kind of delay that from happening.
That'd be pretty beneficial. What I'm fascinated by is as technology is getting cheaper and we're able to do these tests, I wouldn't mind having a day-to-day update on my body, like you see in the movies. For example, I wake up and I take a piss, and my toilet tells me like my BMP panel or tells me my electrolytes, or hey Matt, why don't you eat a banana today? Your magnesium is a little bit low. That'd be pretty cool because I don't know. Maybe Matt here is very fascinated by preventative medicine, and I'm always trying to prevent, hey, instead of having to regrow heart cells because of the MI, how about we worry about the day to day and able to troubleshoot our body as things are happening? Or imagine having a contact lens where it's giving me like an update on my body, what's going on day to day, or tracking my blood sugar. That'd be pretty damn cool.
I mean, you could do
And
blood sugar. You could get one of those things like you put on yourself, and you could have a consistent blood sugar monitoring because a few physicians have done it where they track their like insulin spikes, see what causes their insulin spikes, and kind of they track. I'm not sure what his name is, but there's a physician that did it. He's like a very big preventative medicine kind of guy, and he actually wore the glucose monitor for I think 6 months to a year, just because he wanted to see how his blood sugars fluctuate and kind of what what foods made his insulin spike.
And that's the guy that I remember. His body wasn't good eating soy. Was it pea pods or something like that? So like it's crazy how our bodies are so different. Where his body had a bad insulin spike to specific vegetables that he didn't eat.
Yeah, I'm not sure what. Yeah, we're talking about the same dude. I know he was on. a few podcasts that I listen to. I actually listened to him talk a few times, not just once, because he was on Joe Rogan and he was on the other guy that you sent me a little bit ago too.
Yeah. Okay. Do we want to move forward to the next topic here?
Move forward. Hey, but real quick, have you noticed like milk is pretty sweet? Like I haven't really like I don't know why, but this batch of milk, whatever I have here, is sweeter than I normally would think milk tastes like.
Is it almond milk?
No, it's regular milk from a cow, from a teat.
Okay. I don't really, honestly, I haven't been drinking dairy to be honest.
Yeah.
I'll
I
have
don't.
cheese here
Mhm.
and there, but that's it.
Yeah, I don't drink milk very often either. I used to when I was younger. I used to drink milk all the time. But like I don't know, it's just like sweet. It's weird.
I'm glad you're enjoying it. I'm
Weird to
sure it's
brand.
making their show a little bit better. And the people that are, they're driving home or wherever they're going, whoever's listening, they might want a consumption of milk tonight.
Glass of milk. Yeah, I used to do sometimes when I can't fall asleep when I was younger. I used to do like warm milk and honey. Yeah, I hit the spot.
Okay, I'm gonna expose you, Peter. Peter, man, ever since I know you when you were younger, you before bed used to open up the whole canister, I don't know, cartridge, whatever of milk. You'd
Gallon
even
bottle.
gallon bottle. You'd even pour it into a glass, man. You
Yeah.
just freaking chugged it.
Dude, me and milk go way back, man. Milk was my first friend, man. Milk was so good. I've cut down on it, but still, sometimes you gotta have a glass of milk, man. Got the
Y-
calcium, good for your bones, and I guess it's sweet now, so I guess it's dessert.
You also know that we're the only mammals that drink milk after, like, us are being babies. So after adulthood, we're the only mammal that still drinks milk.
Yeah, we're also the most intelligent mammals in the world.
Do you find that theory to be based on consumption of milk?
It might be. You never know. Probably not. Yo, whoa, what's going on over there, man?
I can't do anything about having a very active home here near Venice. So let's go into diabetes insipidus and SIADH. So let's start off with what is the antidiuretic hormone ADH. It's also known as vasopressin. We give vasopressin for patients that are like critical, that have to have like increased, let's just say, urine output. So that helps with that. It helps also clamp our veins a little bit to increase blood flow. It's stored in the it's made in the hypothalamus, stored in the pituitary, and it helps basically conserve and correct the amount of water that's being released into our body. And it's also has baroreceptors and maintains regulation and things like that. And the people that drink alcohol and the phenomenon of breaking your seal, so a lot of people think like when they start drinking right away, they don't want to go piss because they're going to break their seal and then they keep urinating. Well, guys, that's it's kind of false because what happens is alcohol inhibits your ADH. So what happens is your body overproduces or produces less ADH, and what happens is your body starts peeing a lot more. So if you breaking your seal doesn't matter. Like if you drink alcohol, you're going to be peeing a lot more. That's why you're dehydrated usually after a binger.
Yeah, that's true. I haven't had a binge in a while. I don't drink very often. But yeah, that's what happens with alcohol with the ADHD. And it's cool to actually like realize when you're in a medical field that this is how it actually works, and it's not just like this break your seal. That's how it works. No, there's actually like a medical background to there's actually a process, like a pathophysiological thing that happens in your body why you pee so much when you drink. But SIADH is syndrome of inappropriate antidiuretic hormone. So it's it works with antidiuretic hormone, and you have it inappropriately. So you have too much of it. So what's happening is your body is retaining a bunch of water, and your vascular space gets increased, your fluid gets increased, and we obviously know that these complications are bad for you because they're complications. So what happens is your body retains water. You could have majority of the times what happens with SIADH is like Matt said is neurological issues because your fluid volume increases everywhere in your brain, in your vascular space, and it tends to push on the cells in your brain, which then can cause like seizures or any kind of neurological issues. But the main thing is that you will see with SIADH and what to kind of look for is dilutional hyponatremia. So hyponatremia is low sodium, but you don't have low sodium because you don't have enough salt in your body. You have low sodium because there's so much fluid and it's acting like you have low sodium. But technically your sodium levels that's
I can't
funny.
I can't do anything
But
about what happens
it's
around my
okay.
facility
It's
here.
okay. So it's not, you don't have hyponatremia, you have dilutional hyponatremia because you have so much water in your system where it's falsely lowering your sodium level on like a blood test. What you also get is hypoosmolality of the blood. So you have a lot of fluid. Osmolality has to do with particles. So if you have more fluid, you have less particles. That's the way I see osmolality as. And you're going to have a high urine osmolality because urine is going to be more concentrated. So your urine's going to have more solutes in there because you're not peeing out as much water as somebody that doesn't have SIADH does. And you're going to also have a high specific gravity. High specific gravity because similar concept is you have a lot of solutes in your urine, so urine's going to be heavier. And also a decrease in urine output because you're retaining it. ADH makes you pee. Or sorry, it's the opposite. So low ADH make you pee, and SIADH makes you retain water.
Correct. And as like a nurse, like you have to be careful of what's causing this. So a hyponatremia is having a sodium less than 135, and there's specific disease process that could link this. Meningitis, Guillain-Barré, head trauma like having a subdural hematoma or subdural hemorrhage. We have specific brain cancers because as we're seeing your our sodium go down, normally as a nurse or as a physician, you would be like, hey, let's add on sodium chloride, start it at 75 an hour to help increase sodium. But this is not the issue. Our issue isn't replacing the electrolyte, it's actually correcting the cause of having low sodium, which is the retention of the water. So usually this is a physician's job, but as a nurse you should be thinking about things that are causing this. For example, getting out of surgery, anesthesia could cause this as well. Stress actually makes you hold on to ADH. So it's funny, the people that have chronic stress have high cortisol. And is it myasthenia gravis? It's one of the disease processes. I can't think of it right now, where you have the moon shape and it makes you store more. You're naturally storing more water because you're retaining based on this ADH. And one thing we have to realize is a complication of this is when you have low sodium, electrolyte imbalances can cause you to have seizures. So we have to treat the underlying cause, but also we have to look out for um, complications. So sometimes we'll give prevention medicine like Dilantin to prevent seizures. We will restrict your fluids. So unfortunately, you have to be thirsty in the hospital, and you want to drink more because that's what's happening. And we might give you 3% sodium. So what happens is you probably have to come into the ICU for that, and we just monitor your neurological signs as you're getting the 3% replaced.
Yeah, just to go back to the complications, like the cool things that I learned is like there's a certain cancer called oat cell carcinoma. So if you get this cancer, you have a high chance of getting SIADH because that cancer actually makes its own ADH. And people go into this issue of SIADH with that kind of cancer majority of the times. And also with viral pneumonia causes it as well because it causes hypoxic areas in your lung or not in your lung, but in your lungs.
Slow down, BD.
And like, so if you think about it, your body tries to kind of reperfuse these areas because they're hypoxemic. So what it does is it tries to increase your cardiac output. So it tries to increase blood flow to that area. And the way you increase blood flow to the area would be to increase the volume of your blood. So maybe you could reach it, but you obviously know that that's not how it always works. So that's just something pretty cool that I learned. Old cell carcinoma was actually really interesting.
The oat cell, yeah. It just once you're a medical professional, I'm sure a lot of people that are listening are in it, or they're just the regular listeners that are wanting to learn. It's so beautiful how your body is just this mechanical process that's able to troubleshoot everything. Like we have baroreceptors which stimulate different things, volume, like like just visualizing the heart, which is the pump, and then we have the pipes, and it's able to troubleshoot based on volume what it does. Like let's just say you had a binger, correct? You peed a lot because you inhibited ADH. And what does your body do? It has low pipes, or it has low volume in the pipe. So it clamps down and it increases your stroke volume, heart rate, to what's it called? To help with the maintaining the blood pressure. I think it's just a very beautiful system, and I'm just appreciating it right now.
It's cool how like your body is so stable in like homeostasis. And then like once one thing changes, like with the whole ADH, like it's crazy how like everything kind of messes up. It's cool to like see like the disease process and how it actually works and how it actually works and what it actually causes.
Yeah. Let's go into diabetes insipidus. I seen this one more than SIDH because when it comes to diabetes insipidus, sometimes the patients that are like end of life care or organ transplants, or they'll have like a brain herniation or the brain stem gets affected, they start dumping out a ton of damn urine. So with these patients, you want to look at their urine output. If they're dumping out a ton of urine and they didn't get any Lasix or they didn't get any diuretics, like you kind of want to think about this and start looking at their labs. Maybe they want to do a you know, take some urine, check their osmolarity, see what's going on, because they might need some desmopressin, which is it DDMP? So you want to give them a fake antidiuretic hormone just to kind of stimulate that, just to prevent your kidneys from dumping out so much urine. So
Yeah. I know they'll give
diabetes,
vasopressin. The vasopressin, it's artificial ADH.
yeah, and sometimes patients might need the lifelong therapy depending on their complications. So this one is exact opposite. Instead of holding on to so much water, you're just dumping out a ton of urine because you don't have enough ADH. So your kidneys aren't concentrating the urine. You might have a lot of electrolyte imbalances. One of them is hypovolemia. You're gonna have hypernatremia. So because you're dumping out a ton of urine, you're gonna have a lot of osmolarity inside the bloodstream. So this is the exact opposite. Your sodium is gonna be high now, greater than 145. Your osmolarity in the blood is gonna be increased, and osmolarity in the urine is gonna be decreased. So it's just a cool way to remember that. Just like
It's always
um,
opposite. It's always
it's always the
opposite. So,
opposite.
so if you're hyperosmolar in your vascular space, you're going to be hypoosmolar in your urine. If you're going to be hypoosmolar in your vascular space, then you're going to be hyperosmolar in your urine because like you guys can take into consideration the more you put out, the less or sorry, the more urine you put out, the higher concentration your blood's going to be, and vice
N-
versa.
Now that I think about this, every single time we review like specific disease processes like this, we should like make a mnemonic or look up the mnemonics, which is great for nursing students to help them kind of remember why specific things are happening.
Yeah, you got a mnemonic for this? A lot of H's here. Hypovolemia, hypernatremia, hyperosmolarity of the blood, hypoosmolarity of the urine, low specific gravity, and increased urine output. So the thing is, like, if you could, with diabetes insipidus and SIADH, if you could, to make things simpler, just memorize one of them, and remember the other one is the exact opposite. So you don't got to learn both of them if you don't really want to. You can just learn SIADH and kind of know what SIADH is, and then you know that diabetes insipidus is the exact opposite, kind of like a little cheat sheet. That's what I did in nursing school. Like if you had like Graves' disease versus like hypothyroid versus hyperthyroid, just remember one of them, and then you know the other one's the opposite.
That's actually a good way to do it. And this one, same thing. What's going to cause it? So there's something neurologically that's happening. Sometimes giving antivirals, giving Dilantin for anti-seizure causes this. Lithium for bipolar disorders could cause it. You might have damage to the pituitary or the hypothalamus, depending on what's going on with your patient. And sometimes autoimmune issues might cause this. And treatment, same thing, to be honest. You're just treating the underlying cause. You might be wanting to replace ADH, so your kidneys are going to secrete your water, and you might hydrate them with sodium. But be careful with when it comes to replacing sodium, is your sodium's already high because of the volume depletion. So you don't want it to be, I don't know what the, do you know the complications of having very high sodium?
Yeah, seizures. That's where the neurological issues come in.
Okay, see,
Mhm.
good. I'm
That's
glad I have you here, Peter.
that's why a lot of times when somebody comes with like SIADH or diabetes insipidus, we kind of give them like a precautionary dose of phenytoin, dilantin, just to kind of uh, increase that threshold. Because if you give phenytoin, your threshold's higher for seizures, just kind of just to back you up. Because if your threshold's here, when you say threshold, you can't see me because if you guys are listening, but say your normal threshold is here. If you give anti-seizure medication like Dilantin, your threshold's gonna be up here, so it's a lot harder for you to get a seizure.
Yeah, and that makes total sense. I feel like this is a quicker episode, so
That's okay.
we should give people a little sneak peek of what we do for the after hours, and that's something that we're working on. We're producing like a mini little after show. Basically, if you're listening live on Spotify and iTunes and all that, we can't really swear or kind of, we are ourselves, but we can't give you guys as much like detail or whatever because of HIPAA and all that. So the after hours show, we kind of talk and BS a little bit more, use some profanity. Peter likes using the F word, so I guess we could give you guys a little teaser here because we're kind of shorter on this episode. So how's work been, man?
It's a good. I've been off for the past couple nights. Like I don't know if you guys saw my Instagram, but I met some dude that works for like a plumber's union, and he was all upset because they're like outsourcing jobs and they're able to cut costs. And he kind of gets short hours. Like he loses like one work day a week because they're hiring people from outside the state to come in. So yeah, it's pretty cool. But I try to hit a new max for my deadlifts. Didn't get it, man. 275. I'm stuck in this 275 for 2 of these weeks. Got four last week, 4 reps of 275 last week. I got 4 reps of 75 this week, but it did feel a little easier this week.
So what you want to might sometimes you have to do is just not worry about your max, decrease it down to, let's just say, 90% of your one RPM, whatever, and focus on volume. That's what I did a lot. Like if I was stuck on my squats for 275, cut that shit back to 225, and I would just rep it out, rep it out, rep it out. And I would have hit that damn max for like a month. Because I know, like, when it comes to lifting and the ego and all that, you're very fixated on trying to hit that damn, number and things like that.
Well, it's not my 5 rep max because it's my last set of five. So that's not even close to my 5 rep max. It's just like I want to hit 5 reps for in that weight as my last set. So I'm probably gonna try to get it next week, and if I don't get it next week, I'm probably gonna just do 285, much as I can, like for as much reps as I could do once or twice, just to get a feeling for how heavy weight feels like. I mean, it's been 2 weeks, so I'll be okay. I'll for sure get it next week. I know I'll get it next week. I just want to be past 75. I just want to hit 285. I want to be able to deadlift twice my weight.
I mean, that's a great goal for yourself, man. And you know how Buddha says, think and you will become. So definitely write that number down in your brain, go to sleep, wake up, think about it, visualize it, whatever you have to do. And yeah, I think you're definitely going to get there.
Oh,
So
I
for
know.
me,
I know I am. I'm out of time.
kind of
This milk is really sweet, dude. What kind of brand milk this is? I got an Aldi. Just fucking check out that, dude.
all these pretty good, man. I'm not going to lie. I kind of
Love
sucks because
Aldi.
I've been away from working out and lifting heavy, man. I haven't gone to the gym in a whole month, but I guess I'm, doing pull-ups and things like that.
Pull ups, huh?
So
Did you drinking your milk? How's milk in California?
milk, I
Yeah,
don't drink milk, man. I do almond milk, and
like
that's
at
really it.
all? Huh? You like soy milk?
Soy, definitely not, man. I ain't trying to get more estrogen in my body, bro.
Just soy, dude. You look like you eat a lot of soy lately.
My boobs look already pretty good. I don't need bigger boobs.
All right, you suck at them. Give me some more milk in here with your boobs. Okay, so you want to end this real quick?
Yeah, man. Ask me how's travel nursing.
Oh, how's travel nursing? How is your
I'm
new
just-
assignment? How's the
Thank
weather
you.
over there?
Thank you for asking, Peter. Man, it's been beautiful weather. I'm actually gonna, after this and after we, hang out. I'm actually gonna go to the beach. I'm gonna go read. I'm gonna get some sun. I've been doing a lot of sun therapy because whether you like it or not, man, we're solar beings. We need the sun. Like, the sun regulates us. It gives us energy. It does a whole bunch of things we probably don't know about it. So I love laying out in the sun, man. And now I know how people in Cali are happier, dude, and why the winter blues happen. Like, you need sun, man. So I've been feeling pretty good. When it comes to travel nursing, dude, it's been really cool because on the unit they have such a crisis and shortage of nurses that literally half the unit are all travel nurses, and it's cool as shit because we all kind of help each other out. We all kind of like joke around. We've been all like, I mean, the whole teamwork happens on a whole unit, but as a traveler, we kind of look out for each other just a tad more because we understand. And it's cool because we get to network. We all kind of ask, hey, like, who's your agency? How much are they kind of paying you? And you're able to kind of figure out what agency is doing, what is it called? Who pays you more and how they're treating you. I know I got what's it called? I got a contact information from the crisis rate. So this hospital does crisis, and they sign you up for 8 weeks. They pay you a shit ton, and yeah, man, it'd be a pretty cool gig instead of doing the 13 week.
Yeah, I wonder how that works. Like, how does a hospital go into crisis? Like, is not enough like nurses in the population to like work there? Like, I wonder how that happens.
So within a 1 month time frame, the manager left. So the CNO, the chief nursing officer of the hospital, is taking over as the director right now. And I think they had not 8 or 9 nurses that left. They all went to UCLA. So this hospital doesn't pay as much. You're able to basically go to a different hospital 2 miles away and have like $5 or $6 more an hour. Why
Damn.
wouldn't they do that? They have a stronger union. And what happened is they also introduced a new program into the unit. So now their cardiac program is getting larger. They aren't taking cabbages, but they're taking a lot more Impellas because the doctors are doing them instead of the balloon pumps, and they're doing ECMOs. So
Hmm.
ECMOs are 1-to-1. Like they had an ECMO that came in. Holy shit! I was watching them do something with ECMO with like two doctors, nurses. They hooked up CRT. That patient was 2-to-1. So it takes
Yeah.
two nurses to one patient because that's how busy he is. They have like 6 to 7 1-to-ones sometimes because of the ECMOs, the CRTs. So now you have a unit that lost nurses. Now they need more 1-to-ones, and they're just behind, bro.
Damn,
So
sounds like a fucking shit show.
yeah, it is a shit show, and the nurses are burnt out because they work 5 to 6, 5 to 6 shifts a week sometimes, bro. You have nurses working 5 days in a row. I was like,
All
holy crap, man.
12s? Doing 12s?
12s, yeah, man.
What?
These
Probably doing
nurses are
some nice money though, dude.
uh,
Fuck.
they're making money, but they're exhausted, they're burnt out, and you can tell, man. You can tell when a nurse hops onto the unit and they're already in a pissy ass mood, and they just started their shift. I'm just like, whoa, bro. So it's crazy, like having this third eye perspective, like as a traveler jumping into this hospital and just seeing that nurses are burnt out. And we talk about it all the time, but burnout's a real damn thing. And the nurses that work there sometimes can't see it as much as we do.
Damn. That's very intense, dude. That's pretty cool though. Like, I mean, it's cool to think about, but not cool to actually be there.
And seeing these, like, you know how like you have like staff meetings and things like that, they have only meetings 3 times a week, and their staff meetings are so chill, dude. It was like a BS staff meeting. Like they didn't talk about percentages or taking Foley's out because the risk of infections. And we were laughing around with the staff nurses. Just wait till they replace their staff, till they're full adequately staffed again. They train their nurses to take ECMO and everything, and then it's gonna start back up. That's what
Mhm.
happens. Then they're gonna start. Okay, we're finally staffed. Okay, let's focus on, hey
These
guys,
numbers, these goals,
these
yeah.
these numbers, these goals, and it's gonna go back to the same BS of hearing like just negativity. To be honest, it's as a nurse, it sucks because not only are dealing with patients, so you're getting mentally exhausted from them, the physicians. Now you have upper management that just keeps nagging you about stuff, like, oh, hey, do this now, or hey, we have to. I'm trying to think of ideas, man, of what they talk about. It's just constant BS. Like I told you about Kaiser, like they were looking at the freaking damn trash cans and they're trying to get nurses in trouble for throwing out tubing into the wrong bin. Like, are you guys serious, man? We're freaking tired. And then they get upset because patients develop pressure ulcers or patients develop skin issues while are laying in these beds. Yes, that is happening because you are freaking exhausting us, and we're neglecting the single most important thing of turning the patient Q2, because it does happen, man. You get so busy that you just forget those things.
Yeah, it's cool because you got a pretty cool perspective because you're at different hospitals for an X length of time, and you can kind of see how one hospital does things compared to how another one does things. You can see like their staff versus someone else's staff, and like it's you got a really cool perspective with the whole travel nursing thing. You just get to see so much shit because even though we have like similar protocols, but things are still done a little bit differently in each facility.
Yeah, and one example here is, for example, potassium, right? So in other hospitals, if you have to replace potassium, you would just take it out of the Pyxis and you would just give them potassium. Here, what happened is a patient died from having hyperkalemia. So I don't know if I shared this story on the podcast before. I don't want to repeat myself,
So you
but
share it again. I don't even
quick,
remember.
exactly. Quick background. So patient had high sodium, or I'm sorry, high potassium, and they didn't give anything to correct it. Patient had D5 with potassium as IV fluids. It was taken away. It wasn't discontinued. The nurse gave report to the other nurse. I don't know what happened, but something got missed, and the night shift nurse maybe never looked at her labs. She never asked the physician what should we do about that potassium. They never rechecked it, and then she hung the fluids with potassium back up. Patient fucking coded, died. And
Yeah.
yeah, it's a medical error because no one looked and troubleshooted the potassium. So now if I have to give potassium, I go up to another nurse. I'm like, hey, potassium is 3.1. I'm going to give 40 milliequivalents PO. And she verifies that with me.
Holy
So
shit.
So this is something that's happening in this hospital because of a crazy med error that was missed.
Yeah, and that's what they have to do from now on because like that could happen again. It's one of those issues that should never happen, but it did happen. So now the next step is now you got to do these little protocols to give these little simple drugs like potassium.
Do you remember when we
It's
were
shitty.
in Oakland? So another quick story here is a nurse was hanging tube feeding, and I don't know how she did it, but she freaking jerry rigged it and it connected tube feeding into the peripheral IV, and she gave tube feedings via IV, and the patient died.
Like that, I don't understand how the fuck that happens. Like, damn, like she must have lacked like some common sense. Like I don't want to talk some shit. I've made plenty of mistakes in my life that now to look back up on, it's like why did I do that? But like hooking up a tube feed to someone's IV, like would the tube feed even go through the IV? Like would it even like move because it's so small, like a 22 gauge? Like what the fuck? She probably put it through like a central line, dude. That's some
Yeah.
shit, man. That's scary.
I would love to have somebody on the show, for example, that deals with medical things or lawsuits
Medical
and things like
errors.
that. Yeah, and just seeing like, does the hospital release this information like to the family? Like, yeah, okay, so this is what happened. They died, and this is what we did. We missed this, or hey, the potassium was high. We think that's the cause of death, and we didn't do anything about it. Like, how does the hospital tell that to the family? Like, is there? I'm sure there's truth being told, but what's held back? Because we see this side of healthcare where we know what the heck happened. We see how things went bad, and we saw why the patient passed away, and how much information gets held away from patients that they don't know about, that the hospital shares or doesn't share. I'm very, very curious. We have to
I'm
have somebody on the show. We have to find somebody that's deals with malpractice cases and things like that.
Yeah, I'm not sure how willingly people would be able to like admit that. Like I don't think someone's gonna want to come and say, "Yeah, we didn't tell the family the truth." We just, I mean, we gotta have somebody that's from like a more of like an outside perspective looking in and can kind of see it firsthand, but not directly dealing with it. Because there's no way we could have somebody come in that says, "Yeah, we know this happened, but we actually told the family that this happened." You know what I'm saying?
Well, yeah, it's kind of sucks because you're we're live on the show and people are listening, and people are listening that are not nurses, and people, bring their family members to the hospital. They're gonna be like, "What the fudge, man? Now we're gonna be
Yeah,
scared to leave the patient." Well, yeah, guys, it unfortunately healthcare is
shit
flawed.
happens,
There's
dude. Like
shit
it's all part of
happens.
life.
Yeah.
Like nothing's perfect. If like hospitals were perfect, guess what? We'd probably be living till we're 100 plus years old. It's the mistakes happen. You can't avoid them. Even doesn't matter who you are. Doesn't matter how good of a physician you are. Doesn't matter how good of a nurse you are. Like everyone's prone to mistakes. It's just part of life. Like you could look at your own job, and I'm sure if you're a construction worker, maybe you're a plumber, maybe you're like an athlete, like you make mistakes. Like just we make mistakes too. Unfortunately, our mistakes might be a little bit heavier than somebody else's, but shit does happen. And that's why we have these little protocols, these checks and balances to make sure that these mistakes don't happen because a mistake by a nurse can literally cost someone's life. Like a little mistake with the potassium that literally cost somebody their life. With the tube feeds that cost somebody their life. It's not like hey, you like set up this wall wrong, and now we gotta knock down the wall and then we put it back up. Like there's not always a way to come back from it when you're dealing with people and death. People don't always recover from your mistakes or from our
Unfortunately,
mistakes. Yeah.
unfortunately, yeah, it's
Yeah.
just the truth about healthcare, man.
Yeah. All right,
But
guys. Well, thank you for. You want to say anything else, or are you just gonna end it?
I was gonna actually end it, man.
Okay.
So people that are
There
okay,
you
no,
go
no,
again. The
another
boys.
sirens, man. Let me go find out what's going on. Maybe I could help. Um, but let's sorry, I lost my train of thought there. So this is a little teaser of what we're gonna talk about when it comes to the after hours on Patreon. We are working on releasing this. So if you listen this far, we are planning on releasing it sometime in May. And yes, Peter, I said May. So now we have to be accountable and actually get it done in May.
We still got a whole
So
March or and April. Oh wow, I completely forgot there's a month of April
I'm glad,
to deal
man,
with.
because there's just so much to do. But anyways, guys, it's going to be a way to support us and the show so we could keep on growing, probably hire somebody else so we'll get more work done and more quality content to you guys.
Yes, sir.
Wrap it up.
All right, guys. Thank you for staying with us. We love you all. Do my piece, Reagan. So just to tunnel back to the beginning, we talked about something called tissue nano transfection technology, which is a little chip that they can put on your skin and has a potential to to increase cell proliferation and also cell division. It can zap cells to changing their function. It could change skin cells to vascular cells. And we also talked about SIADH and diabetes insipidus. They both deal with ADH. If you guys want to learn a quick way to learn these two, I would say just learn SIADH, what it does, what it causes it, kind of the symptoms. And then remember that diabetes insipidus is the opposite. So instead of memorizing both of them, just memorize one of them, and then the second one will be natural because it's just the exact opposite of it.
That's right. And if you guys want to have specific topics talked about or any different topics, if you want Peter to talk about who knows what, some comedy, let us know, drop a comment, and we will get that to you guys.
Yeah. Peace out,
We'll
guys.
we'll chat with you guys next week.